So after you've performed laparoscopy to verify that there are no other injuries, then look up at the diaphragm where we see a diaphragmatic tear. We're pointing to the full length of the tear using both instruments. And this is an injury that needs to be closed, and we're choosing to do this with an Ethibond suture, which is a braided non-absorbable suture, typically useful for the diaphragm, on a CT1 needle. So we're placing this initial suture along the corner of the tear. Laparoscopic suturing is one of the most difficult laparoscopic skills to learn. It's something that will require quite a bit of practice. So we don't want you to stress if you can't get it right after many tries, but this is definitely something that can be learned through practice. And here we're throwing an intracorporeal knot, a surgeon's knot, followed by 2 additional throws. And this knot is going to be just like your instrument tie that is performed outside the body. And intracorporeal knot tying, just as intracorporeal suturing, is a very challenging skill set. However, it's a skill set that we believe that is important in the low resource setting where other technologies like ligature or staplers might not be readily available. It's also a skill set which confers general skills in laparoscopy. So if you get good at doing this, you'll be good at other fine movements required in laparoscopy. So we're now cutting the tail as you would in open surgery using endo shears. And now we will commence the suture closure of the diaphragmatic tear. Now, if you find that the tear is under quite a bit of tension, then we would recommend that you use interrupted suture, even with an extracorporeal knot pusher. In this particular case, it doesn't appear to be a lot of tension on the wound, so we're going to run this. Here, we would like to see that the bites are fairly evenly spaced, so that there are no obvious gaps in between the sutures. And for this, typically, we like to hold the needle right in the middle and then do a sharp wrist turn in order to turn the needle in the tissue without injuring the tissue. And being sure to not lock the suture and tightening up between each throw, just as you would in open surgery. Now, the towels below represent other intra-abdominal organs. Of course, the diaphragm is above the liver and the stomach and the spleen, and you want to avoid touching those organs or injuring them. And so we're trying to avoid touching the towel with our instruments or with the needle. And again, tightening after each throw. And this will be required when you are using a suture such as an ethibond, which slides. And again, just really making use of a lot of wrist in order to make these sharp turns to achieve the angles necessary when you're closing the diaphragm at this angle. When you grab the needle with your left hand, you want to be sure to not grab the tip, the exact tip of the needle, which could dull your needle. We're grabbing just behind it. And it looks like this tear is going to require one more throw, which we will do right now. Again, trying to grab the needle roughly in the middle of the needle and making use of extreme wrist movements in order to make that turn. And sometimes the needle needs to be adjusted to accommodate this, this angle of approach up to the diaphragm, which again, admittedly can be challenging. Again, trying not to grab the needle exactly at the tip, but just behind the tip. So after we've reached the end of the defect, we are now going to tie the suture to itself by making a loop with that end throw and treating that as an end. Before we do that, we're going to just tighten up on the entire suture line to make sure it's tight, and then we will perform that again, that knot with a surgeon's knot, followed by 2 throws. And after that, we will cut the end using the endo shears. And remove the suture from the body.